Hello, everyone, and thank you for joining me today. My name is Julija, and it is really my pleasure to present my research findings on the intersection of the autism and Down syndrome. And I appreciate your presence, and I look forward to an engaging discussion. So before we actually go into the details, let me outline what I will cover today. So the presentation is being structured around 6 sections, as you can see on the slide. And as it was already mentioned that this presentation, it is going to last at around 20 minutes, after which I will be happy to answer any of your questions. Autism is a neurodevelopmental condition which is actually being characterized by challenges in speech, social interaction, and repetitive behaviors, while Down syndrome, on the other hand, is a genetic condition leading to developmental delays and intellectual disabilities. Despite their distinct definitions, there is an overlap in their behavioral presentation that has puzzled the researchers for decades. With this initial understanding, we are going to explore the historical perspectives and evolving recognition of autism in individuals with Down syndrome, setting the stage for why this dual diagnosis, known as DS-ASD, has been challenging over the years. Until 2013, autism was categorized as a distinct condition within a broad group known as pervasive developmental disorders, or PDD. However, the DSM-5 revision in 2013 consolidated autism and 3 other related conditions under the umbrella term Autism Spectrum Disorder, and children diagnosed under this framework are identified as having ASD and are being assigned as a severity level. Throughout this presentation, I will use ASD or autism to refer to the spectrum. The global prevalence of autism spectrum disorder is at around 1%, while in Canada, the prevalence is about 2%, ranging from 0.8 to 4.1, depending on the province, and the condition being 4 times more prevalent in males than in females. We are going to shift now our focus to the origins of the Down syndrome. Down syndrome is named after Dr. John Langdon Down, a British physician who first described this condition in 1866. After nearly half a century of this description, a researcher, Charles Davenport, suggested that Down syndrome and other intellectual disabilities could result from chromosomal changes, but could not prove this. However, with the development of the cytogenetic techniques in the 50s, the French geneticist was able to identify that individuals with Down syndrome have 3 copies of chromosome 21 instead of 2, and this led to an alternative name, which is known even until today, which is trisomy 21. I will briefly explain the 3 types of the Down syndrome. The most common one is being known as a full trisomy 21, where every cell of the body has an extra chromosome 21. The second type is known as translocation, where only a fraction of the 21st chromosome attaches to another chromosome. In the rarest form, it is known as mosaic. Phenotypically, these 3 forms, they are all looking alike, and the main differences lie in the levels of intellectual disability. Down syndrome, as you already know, is one of the most common genetic conditions, and 1 in every 750 newborns in Canada is born with this condition. And currently it is being estimated that there are around 45,000 individuals with Down syndrome in this country. In this side-by-side comparison, we are going to explore the behavioral aspects of autism and Down syndrome. The first row highlights the most striking differences of these 2 conditions, where individuals with ASD often avoid eye contact and prefer to be alone, while those with Down syndrome are more social and they engage actively with others. This contrast has unfortunately historically fueled misconceptions about the co-occurrence of these 2 conditions, leading to decades of oversight in diagnosing ASD in the DS population. Moving to the next sections, we see areas of similarities, particularly in the communication, sensory sensitivity, and even cognitive ability, where both conditions exhibit unique challenges. However, they also have some commonalities, like, for example, both of the conditions have speech delays, sensory sensitivity towards different stimuli, and different levels of intellectual disabilities. For a long time, it was believed that autism and Down syndrome could not coexist, and this misconception as we already mentioned, stemmed from the general observation that individuals with Down syndrome are friendly and happy and without any neurodevelopmental challenges. However, this view changed in 1979 when the Japanese physician published a pioneering case study describing a child with both DS and ASD, and this prompted researchers to further investigate this, and today published research confirms that ASD is significantly more prevalent in individuals with Down syndrome, about 42% compared to around 1 to 2% in the general population. As a response of this, the American Academy of Pediatrics updated its guidelines and now recommending ASD screening for all children with Down syndrome at age of 18 and 24 months. And you might be wondering, given this acknowledgement and the revised guidelines, why are we still discussing this challenge? So let's have a look at it. While the DSM-5 diagnostic guidelines apply to all children, including those with Down syndrome, part of the problem is that not everyone is on board with these recommendations. And while neurotypical children are regularly screened for ASD at the recommended timeline, children with Down syndrome, unfortunately, are not always screened for this co-occurring condition. On top of it, early screening can lead to early diagnosis, as we already know. And the average age for diagnosis of ASD in Canada is at around 3.7 years of age, but there is no data available that shows at what age children with Down syndrome have been diagnosed. As per the published literature, however, there is a significant delay, and these children are mainly diagnosed when they're 7 years old or even older, or they're not even diagnosed at all. And this brings us to summing up the current problem, which states that despite a higher prevalence of ASD in children with Down syndrome, there is often a significant delay in the diagnosis compared to the general population. This delay is not just a statistic or a number, it actually represents a missed opportunity for early intervention that are crucial in supporting these children's development. Some of the main problems that leads to this is lack of screening tools, which haven't been validated in this population. The overlapping of symptoms of these two conditions is also making it challenging for clinicians to capture the ASD presentations in these children. And of course, there is still lack of awareness among the healthcare providers about these two co-occurring conditions. So why did I decide to undertake this research actually? In general, there is lack of research on individuals with Down syndrome and no research on the co-occurring DS and ASD in Canada. During the literature review stages of this study, no publications were found that address this problem in the country. As already mentioned before, delayed diagnosis prevents these children from accessing early interventions, which are mostly effective when they're being applied under the age of 5. And lastly, there are still clinicians who argue that individuals with Down syndrome do receive some sort of a support already without trying to understand that coexistence of DS and ASD brings in a whole new presentation that requires different set of interventions, and these are not usually offered to children with Down syndrome. As a result of this study has been structured around 2 objectives. And as I have already mentioned so far, I decided to further explore this problem, and I wanted to identify barriers that health professionals are facing in diagnosing ASD in children with Down syndrome. And knowing that understanding only one side of the problem isn't enough, I also decided to include the caregivers and hear their stories. As a result, I wanted to explore what were the diagnostic journeys they went through with their children, what kind of challenges they faced while they were navigating the healthcare system, and what was the overall impact on the family dynamics. So this research study was designed as a convergent parallel mixed method design, which allowed me to apply both quantitative and qualitative framework. And both of the data were collected at the same time, but the analysis was done differently and independently. The qualitative component included a narrative research approach. Through this one, I actually allowed the caregivers who accepted to be interviewed to share their story first in their own words, and then I applied some of the semi-structured questions of the approved questionnaire. On the other hand, the quantitative component included a descriptive survey design, and we're going to have some details on this. So this is some of the timeline that the study went through. Following the departmental approval of the proposed research study, which was in September of 2023. The advisory committee was formed between October and November of 2023. The RAB protocol was submitted in December and then approved on February 6th of this year. The announcement of the study was done later that month, with preliminary analysis being done in May. And I submitted the report for a review by my department in June, and this is how this defensive is being structured. And in April, I also requested an amendment of the protocol, which was approved on May 28th, and I will discuss about this a bit later. So the inclusion criteria applied to both caregivers and health professionals. We wanted to include caregivers who have children with Down syndrome under the age of 18 with a confirmed ASD diagnosis, while healthcare professionals were supposed to be involved in the care and treatment of children with Down syndrome, and they should have been practicing in Canada. That was the original protocol. However, due to the increasing number of requests for this survey from an international audience, an amendment was requested so that we could start collecting responses from clinicians who are based outside Canada. Exclusion criteria applied only to caregivers, which means that we could not include caregivers who have children with Down syndrome without confirmed ASD at this stage. We designed 2 structured surveys. They were designed in red cap, one for the health professionals and one for the caregivers, completed anonymously. Interviews were done only with the caregivers, virtually over Zoom. They were audio recorded and transcribed verbatim. The dissemination of this study was done through different platforms. The poster that you're seeing on the slide was the one that was shared with the health professionals, and we did this through the hospitals, professional associations, LinkedIn, emails, chats, as well as conferences. While for the participation from the caregivers, we reached out to the Down syndrome associations. We reached out to their Facebook platforms. This was also shared through emails as well as through chats. So let's have a look at the results. On the slide, you can see some of the demographic profiles of the responses that we received from the caregivers. So the analysis, it is based on 21 responses from these caregivers. Most of these responses came from Ontario. Most of the families that reached out to us have only one child. Their racial background is predominantly white. These were mainly families with 2-parent structure. They were well educated, and most of them, they reside in urban areas. So based on some of the questions that we have wanted to know from them, we have identified that some of the most common early observed ASD signs based on the caregivers' responses were repetitive behavior. And in fact, all of them have mentioned that their children were exhibiting these signs and symptoms in the early stages. They were followed up by the speech delays and regression, excessive reactions to sounds, textures, or even visual stimuli. These signs and symptoms were mainly observed by physicians, but they were also noted by the occupational therapist, speech and language pathologists, and sometimes by friends and family members. As you can see, most of the caregivers, they have rated their level of awareness on the DS and ASD as moderate. And we actually defined this as, I understood it was possible for my child to have autism, but I lacked detailed knowledge about this. And this is some of the most important finding that we actually got from the survey from the caregivers. The area in the green on the chart is showing the time when the symptoms started to emerge in these children, and the columns are representing when the diagnosis was made. The mean age for the symptom onset was at around 2.76 years. The mean age for the diagnosis was at around 6 years old, and there was a wide range of delay between the onset and the diagnosis, ranging from 1 to 9 years. Based on this, we can clearly see that most of the children started to show the signs of symptoms of ASD between the age of 1 to 3. However, the diagnosis was made age 5 and above. We also know for sure that ASD in neurotypical population, it is highly associated with family history of the conditions that you can see on the slide. So we wanted to know if this was the case about the children with DS and ASD, and this is what we actually found out. 38% of the respondents mentioned that they do have a close family member with ADHD. They also 33% mentioned that they have family member with ASD, and 29% have a family member with a learning disability. So when we did try to correlate these findings with the onset of symptoms, we found out that there is a moderate negative correlation suggesting earlier ASD symptoms in families who have additional family members with ASD and even learning disabilities. And on this slide, you are actually seeing some of the themes that we identified from the interviews, and some of the most common themes are the diagnostic delays and the confusion, and I have mentioned some of the responses that we received from the participants. Additional themes that were mentioned were the challenges in navigating the healthcare system, and as well as lack of tailored interventions. As it is being mentioned by most of the caregivers, there is a gap in service specifically designed for children with Down syndrome. They are stating that there is either for Down syndrome or either for autism, but nothing in between. One of our area of concern was the family dynamics, and from the qualitative analysis of the service, from the open-ended questions, we did find out that there is a disruption in the family dynamics in these families, and we also found out that they are exhibiting high level of challenges and barriers when they were going through the ASD assessment. And one of the respondents actually sums up everything, that there is lack of medical service, wait time, cost, point of care for care, and it's the entire broken system. On this slide, you are actually seeing the responses that we received from the health professionals. As I mentioned, we first started with receiving responses from Canada, but that one was after that expanded to other regions. So far we have received 102 responses from 8 provinces, 8 from the States, and 42 from other countries, ranging anything between Brazil and even Singapore. For this particular presentation, however, the analysis, it is based on the responses from the survey completed by 62 respondents from 8 provinces. And as you can see on the slide, we have received responses from a wide range of health professionals as well as allied health professionals. That is going to give us a great understanding of how this condition it is being seen from different angles. On this slide, we are presenting the awareness about the co-occurring condition and what is the level of confidence of identifying ASD in children with Down syndrome. What we did identify is that probably at around 1/3 of the respondents rated their awareness level is very good and excellent. And when it comes to the confidence, they do mention moderate confidence level, and that's probably at around 1/3 of the respondents. And only very few respondents mentioned that they do feel very and highly confident. However, what we found out is that most of these responses are coming from highly specialized professionals who are practicing in developmental pediatrics, psychiatrists, or these are coming from individuals who have worked many years with children with Down syndrome. We also identified differences in the assessment practices, ranging from assessments only when certain signs and symptoms are being observed. So clinicians were not really proactive in this manner. Some even mentioned that they will consider only when there is a concern raised by the parents, and very few actually follow the recommended guidelines, which we saw in the first slides. On this slide are being listed the most common concerns that prompted the clinicians to consider ASD, with lack of eye contact being number one of their concerns, followed by lack of social engagement and repetitive behavior. Now, these concerns are the ones that have been mentioned by the clinicians. Parents themselves, on the other hand, are mentioning something completely different. For them, the most concerning symptom was the repetitive behavior, followed by the speech delay and sensory stimuli. This is quite important because it is really necessary for both of them to better understand what is necessary to be observed and how they can exchange this information during the clinic visits. We also asked the health professionals what are the most common challenges that they are facing. And instead of we giving them the open-ended question, we actually did something else. We tried to gather the most cited challenges in the literature, and we asked them to rate them. As you can see, most of them are being actually rated as moderate. However, a few of these have been rated higher than the others, and those are the different presentations of ASD in children with Down syndrome than in the neurotypical population, and the lack of specialized training that would help them identify these characteristics. We also asked the health professionals what would be needed for them to improve their awareness of DS and ASD, and these are some of the responses which were actually validated by many more. So they're calling for more training, for guidelines and protocols on DS and ASD, as well as interprofessional collaboration, especially between the primary care providers and the specialists as well. And this brings us to the discussion and just summing up everything that we have discussed so far. And I just want to recap the insights that you saw today are coming from 93 participants, including 62 health professionals and 31 caregivers. Both caregivers and health professionals raised concerns about challenges in diagnosing ASD in children with Down syndrome. There are also screening variability among the clinicians, and families do face significant emotional and logistical challenges in managing DS and ASD. Our initial assumption was that the diagnosis is delayed in Canada, and we could actually validate this. Even though the signs are present under the age of 3, the diagnoses are being made mainly at age of 6 and even above. And lastly, there is a myriad of systemic challenges that these families have to face. Some of the limitations that I want to discuss is that this study did not actually differentiate between the different levels of autism that were mentioned initially. Early symptoms of ASD reported in the study were based on retrospective recalls, and this could be a subject of inaccuracies or even biases. We also reached out mainly to the Down syndrome associations to recruit the participants, and this approach may have excluded families of children with DS and ASD who are not members of these associations, and surveys and interviews were conducted exclusively in English, which may have limited participation from non-English speaking families. As for what comes next, I will have to complete the analysis of the remaining responses, work on the publication, work on knowledge translation, as well as identify ways to continue this work on the DS and ASD co-occurrence in the country. I wouldn't have been able to do any of this work with my amazing team, and I'm really happy for them being today to support me, and I hope that I can collaborate with them even in future. And lastly, I want to mention that this study has been presented so far at 6 conferences. 4 of them were in Canada, 1 in US, and 1 in Italy. And on the right hand are the organizations that have supported me to present this study in all of these conferences. And I wanted to thank you all for listening to my findings. And if you have any questions, please come in.